Welcome everybody to this month's video message. So as you can see, I'm here in an operating theatre at St Peter's Hospital. And I've come to hear about a quality improvement project. Now you'll all know we've been messaging and talking a lot about how we support clinical teams and non-clinical teams to develop the skills and take the initiative in relation to improving the quality of care we provide. And I got to hear about this fantastic project that one of our colorectal surgeons, Mr. Jonathan Trickett, is leading in relation to improving the outcomes for patients coming into the hospital and requiring emergency laparotomy surgery. For those members of the team who don't know what a colorectal surgeon does, although I suspect they might have some imagination on that, please would you just, for the audience, just describe an average day in your world?
So most of my job is involved with diagnosing bowel cancer in patients and then treating it.
Yeah.
So seeing patients in outpatients, then doing an endoscopy to diagnose and take a biopsy, and then planning and performing surgery. And a lot of the week is taken up doing the surgery, which is basically removing bowel cancers. We spend a lot of time and resources looking at elective work, which was booked work for cancers.
Yes.
But actually the emergency work is very important not to neglect, because if you look at the risks of elective surgery, they're really very low compared to emergencies.
Yeah.
So clearly we can make a bigger difference in reducing the risks and improving the outcomes in emergency surgeries. Our mortality outcomes are actually less than the average. The average for the country is about 11 to 13%, and we're 8%.
So we're starting in a good place.
We're starting in a good place.
Fantastic.
The emergency patients are usually older, so at higher risk.
Yeah.
They come in and you've got very little time to prepare them and reduce the risks before theatre. You maybe have got an hour or two.
Yeah.
Because every minute, every half hour counts in terms of the outcome.
Yeah.
And because they usually, the patients we're talking about need an emergency laparotomy, so they need to go into their tummy and sort out a problem. Usually they've got a perforated bowel. Tend to be, out of the age range we talk about, tend to be more elderly. They're more prone to developing these sorts of complications with all the associated heart and kidney and lung problems that go with that.
So how do they present?
Usually it's sudden onset of abdominal pain.
Yeah.
They'll come to A&E in an ambulance, and we've got to pick them up as soon as they come through the front door and get them better as soon as possible. So that's where this pathway that we've developed at Ashford and St Peter's kicks off as early as possible. And we get all the 6 key factors done and dusted as soon as possible, so we get them through to the treatment and make them better and reduce the complications that can occur and improve the outcome.
And as I understand it, that work is part of a wider sort of across Kent, Surrey and Sussex piece of work.
What we're doing is trying to spread best practice so that everyone comes up to the highest level. It's often a lot of basics things, you know, it's 6 steps we're thinking about, but we're auditing that and trying to get embedded in every trust and get compliance as high as we can to get the best outcomes.
So it sounds to me in some ways that colleagues will be familiar with the sepsis 6, and what I can see there is that actually the wide engagement, the identification of your patients is very important, isn't it? But to get them into the right place quickly. What's the help you need from the rest of us to really make this piece of work as good as it could be and get our patients the very best benefit?
So what you need to focus in on is the 6 important points so that you can embed that and optimise compliance.
It's a truly multidisciplinary effort, and many different, although you're leading this work in the hospital, many different members of our team will be engaged in delivering this care. So now I've been joined by Chrissy Redmond, and Chrissy is our new emergency surgical nurse coordinator. Got that right. So Chrissy, welcome.
Thank you.
Can you just, for the benefit of those of us that don't know, because this is a relatively new role, what does an emergency surgical nurse coordinator do all day?
So it is a new role to the trust, and it has actually several parts to it. The first part is actually involved in theatre, and I'll be helping to coordinate the emergency list that we have on a day-to-day basis.
I see.
So when doctors have an emergency and they need to actually put the patient on the list, they'll come to me and I'll book them on.
And that's cross-specialty, is it? So you could be negotiating with the vascular surgeons or the urologists or the colorectal surgeons?
Yes. My background is intensive care.
So you're an intensive care specialist nurse, right?
Yeah. So coming to theatre is actually quite new.
Yeah.
But what I can do is actually recognise and pick up when people are perhaps deteriorating after they've had surgery, and also, as Jonathan was saying earlier, about the new acute abdominal pathway, part of my role is to encourage the use of that pathway So when a patient actually gets put onto it, I can join the doctors and help to instigate the antibiotics, the fluids and the things like that they actually need.
Clearly, as a member of the team, you become embedded, you're working with your senior consultant colleagues regularly, and you become very familiar with their clinical approach, and I can absolutely see the benefit. So you being the glue that kind of holds that team together. The message I really took home from that was that, as Jonathan said, the audit of care we're already providing demonstrated that our mortality rates were already better than the national average. But he, as a lead clinician working with his colleagues and clearly a wide multidisciplinary team, weren't satisfied with that. They wanted to seek out where the opportunities were in that pathway of care to improve it even further. And I would absolutely urge every single one of us to think about that and think about how we apply that in our everyday. Always looking for that opportunity to prove what we're doing, learn from others, and therefore benefit the care we provide our patients. Now, if you're interested in doing anything around quality improvement, please make contact with me or with Mark Hinchcliffe, who's leading work. Some of you may already have had that opportunity, so that we can plug you into the tools, the techniques, and the information available for you to start projects of your own.